roughly the same number in the room. I was just pumping Peter up, saying how wonderful he is. Peter is the President and Senior Scientist at the Institute for Work and Health in Toronto, in Canada, one of the world's preeminent centres of occupational health research. And clearly we have a big focus on occupational health here in the school. I was just saying Peter's on loan to Canada from Australia, as you'll hear. But it seems to be a long-term loan, Peter, so I'm not sure when you're coming back. You did spend a few years with us here about a decade ago in Monco, maybe a bit longer. And we've had quite a lot of collaborations over the years, so it's wonderful to have you back. For those who don't know, the World Congress of Safety and Health and Work is on in Sydney next week, and that's the added bonus for Peter coming to visit us here, as he gets to go to that as well. So without any further delays, I'll hand over to you, Peter, for your presentation, and then we'll have Q&A at the end.
And about 15 minutes for Q&A? Yeah. Okay, I think I should be right. Thank you, Alex, and it's great to be back at Monash. So yeah, I'm going to talk a little bit about some research projects that we did during the COVID pandemic. I'll also sort of reflect a bit. I mean, the findings I think are interesting, but I think some of the challenges and future directions that we've had to take as an organisation are also interesting and worth speaking about. So first of all, I'm going to tell you a little bit about the Institute for Work and Health, which is where I currently work, as Alex mentioned. So in terms of our organisation, we've recently gone through a strategic planning exercise for the next 5 years. And these are sort of parts of our vision, mission and values that we've put forward. We are an academic research centre, but we do have a big focus on mobilising the research that we produce. And so we're always trying to think about ways in which we can communicate, mobilise our research so that it's used by policymakers, employers and workers. Part of the focus, or the renewed focus of our organisation as we moved into our next 5-year plan, was around inclusivity at work. And so we realised that return to work after a work injury is one thing, and it's still a really important area. But there's a number of people who don't have work injuries, but other health conditions who also want to work. And for us as an organisation, we see that within our mandate around creating more inclusive work environments. In terms of the values, the excellence, integrity and innovation is how we do our research. So we rely a lot on peer review to demonstrate both the excellence in our ideas in terms of funding and the excellence of our outputs in terms of peer review publications. Although that is one of the challenges, which I'll be talking about at the end. Respect, collaboration and equity is how we engage with other stakeholders in terms of doing our research, and accountability. As a recipient of a large amount of government funding from the provincial government, we always need to demonstrate the stewardship, the responsible stewardship of our resources. In terms of our directions as an organisation over the next 5 years, we are looking to advance the science of work and health, which is producing more research in that area. Expanding the reach and impact of our research, and this is, I think, relevant as we come out of the COVID pandemic, are there ways in which research organisations can bring together people around high priority impact topics. And so one of the unique features of the Institute, because we're perceived as independent and rigorous, is that we're able to get people in a room who normally wouldn't talk together. And so part of our new strategic direction is thinking about how we can play a more active role in that space. I think we found it a challenge during the pandemic as an organisation. Strengthening the work and health ecosystem involves the providing training opportunities for young researchers in work and health, and also building data capacity, and then ensuring that we're a safe and healthy place to work ourselves. In terms of our research focus over these next, I was talking about this morning to a small group. I hope I didn't miss any of them. In terms of our research focus, so this diagram describes what we do. We look at how work impacts health, how health impacts work. We look at that from both a worker level, a workplace level, and a systems level. Because we're multidisciplinary, we often approach questions from a multiple variety of vantage points. And in terms of the priority topics that we see us wanting to make an important contribution to over the next 5 years, include the changing nature and future of work, societal impacts, broader societal impacts and how that impacts work, organisational context and workplace size, so trying to understand how those things are important, addressing long-standing issues around fatalities, musculoskeletal conditions and critical incidents, understanding occupational health and safety and return to work in a more diverse and inclusive workplace, and then mental health at work are the priority areas that we're focused on. So in terms of today's work, I just have a few acknowledgements I want to make. John Ojuk and the Occupational Health Clinics for Ontario Workers. So within Ontario, there's 6 research centres that are funded, and then there's also a number of health and safety associations. The Occupational Health Clinics for Ontario Workers, or OCAL, are focused on assessing a lot of the working environments within workplaces within Ontario. And John has been instrumental in terms of better understanding the psychosocial work environment. And John really was the catalyst for a lot of the activities that I'll be presenting today around mobilising different groups to collect information about what was actually happening during the pandemic. We had an ad hoc pandemic survey group, which were helping us design the different surveys that I'll be putting forward today. People who were quite active on that were Dorothy Wigmore, Laura Lazansky, and Alec Farquhar. And then co-authors on each of the papers are those listed there. Leonel from OCAL, Kamiko from EDFO, Guy Potter from Duke University, Cam Mustard from IWH, as well as for one of the studies I'll present today, the Elementary Teachers Federation of Ontario was quite instrumental in terms of getting that study up and running, and that includes Tracy Edwards and Elizabeth Mitchell. I will add that none of the work I'm presenting today was funded through a peer-reviewed research grant competition, none at all. There was a funding opportunity which occurred early in the pandemic, which was quite intensive. They tended to fund a lot of medical research. No one really was concerned about the work environment at that particular point, and then the funding ran out. So key messages from today. I've got a couple. So the first is that the work I'll be presenting on today is around infection control practices and the adequacy of those as they were perceived from workers during the first year of the pandemic. And they were associated in a stepwise fashion with symptoms of anxiety in fairly consistent ways across 3 different samples. And I think one of those key messages is that physical risks, so things that protect the worker from physical injury or preventative practices, are associated with mental health outcomes, and vice versa. Things that prevent workers from mental risks at work can also be associated with physical outcomes. And I think we do need to think about the comprehensiveness of the way we approach physical and mental risks within the workplace. Among educators in Ontario, there were important differences in the work environment between those that were engaged in online teaching compared to those that were engaged in in-person teaching. We had and I'll talk about it a little bit around the environment within Ontario as I described the different phases of the pandemic. But teachers were thrown in to online environments in ways that I don't think were completely well thought through, and we can see that in some of our data in terms of less predictability, more role conflict, and less support from supervisors and co-workers. Leveraging connections between prevention system partners and organised labour really helped enable the rapid collection of survey data on 3 separate occasions. We were fortunate in that the groups we were looking to engage with, healthcare workers, non-healthcare workers, but in highly unionised work environments, and educators are heavily unionised, and so that helped us reach a large number of workers relatively quickly. It does mean that we missed out on some of the other industries within Ontario that don't have a large union presence, and as a result, we weren't able to collect that information. Some of the sort of reflections that I'll be talking about is given the increased use of convenience-based samples and lower response rates in general, we do need to think increasingly more about how to better correct for selection bias in terms of the work that we do. And we've recently got a grant funded to try to think about new ways to do that. And as an applied research organisation with the goal of mobilising research, so the Institute, we are facing this increasing need to balance peer-reviewed work that demonstrates our rigour and excellence with an increased demand for information that wants to know about things as we're finding them out. And so trying to balance that tightrope has been an important part of as we look for the next 5 years about how we're going to better do that as an organisation. And I've got a few reflections just at the end there. So this is what COVID looked like in Ontario. So there's 2 things on this graph. They sort of follow hand in hand. On the left-hand axis that you look at them is the number of cases per day in Ontario. That ranges up to 120,000. And on the right-hand axis is the rate. And they, of course, because we didn't have huge decreases in the population or increases in the population over that time, they tend to follow in a cyclical pattern. The work I'll be presenting on today focuses on the first wave of the pandemic, where relatively, if you compare it to the waves that followed, were relatively small in terms of case counts, and a little bit of the second wave. So where we'll end up is at the end of 2021 in terms of the teacher survey, the educator survey, which is as rates are increasing. Schools, I actually came out to Australia in March for a holiday in 2020. And then school went online and we thought that's okay because our kids are out of school for that week. They never went back until the September. In Canada, we do the September through June school year. They didn't go back until September 2020 and then ended up closing again as we moved into the new year in 2021 for the remainder of that education session, not returning until September of 2021. So there was a lot of time for kids to be out of school, a lot of time for parents to be balancing having young kids in the house that were meant to be on learning. My son got very familiar with YouTube during that time, not a lot of it educational, unfortunately. And then, again, I won't be talking about the Omicron wave. I will add that testing pretty much, this is laboratory confirmed testing. It did stop for almost anyone but essential workers during the Omicron wave. And so that's a real underestimate of how much things increased. But I guess relative to Australia, we did experience a lot more in terms of COVID cases and rates. So first of all, I'm going to talk about the adequacy of infection control practices. So there's 3 samples I'll be discussing today. One is healthcare workers. We managed to collect responses from healthcare workers between April 7th and May of 2020. So this was fairly shortly after sort of the pandemic started and we wanted to start mobilising. We did this survey again through a variety of different healthcare unions. We had just under 7,300 people sort of start the survey, of which just under 6,000 provided us with information on the main outcome, which was around symptoms of anxiety. In terms of the non-healthcare sample, we did that sort of as the healthcare sample was in the field. There was an interest in surveying non-healthcare workers as well, people who were still going to the workplace. So we did that survey from April to June of 2020. And in that sample, we had 5,000 people which started the survey. 3,747 were employed on March 2nd of 2020. So they were employed, and then something happened during the pandemic that we could examine and had information on the main outcome. A lot of that attrition there is actually from people just not responding to whether they're employed on March 2nd or not. But we do have a mixture of people from education, government, healthcare, retail and food services, to a lesser extent in manufacturing. And then our final survey was conducted on elementary school educators. So elementary school is up to year 8. And so that survey was conducted as schools were reopening. So schools reopened in September 1, or probably September 2 or 3, given there was a Labor Day in there. We did the survey between the 23rd of November and the 21st of December, 2020. As I said, shortly after we finished this survey, schools closed again, which gives you an understanding of what was happening around transmission at that time. It was steadily increases that we hadn't seen in that first wave of COVID. And so there was a general sense of anxiety and hesitation among workers. For that survey, we included just under 6,000 people responded to the surveys, of which just under 5,000 were at the school worksite for the whole week, which I'll be presenting in part 1 around infection control practices. And then we did have a reasonable number of people who some were engaged either in person and some were engaged online, noting that as they reopened schools, they encouraged most students to come back in person. They did allow a separate stream of online education, so virtual instruction at September starting, but we had fewer respondents in that, but I'll use that part of the second part of the presentation. So in all, not bad in terms of the ability to recruit fairly large samples of workers during this time period. They were all web-based surveys, so there's a link distributed via email to members of different labour organisations. They were told if they wanted to, they could pass it on to colleagues and friends. There wasn't a way to validate. I mean, we had questions about, are you working, but we couldn't validate the responses to those questions. They were convenience-based samples, so it did preclude the estimation of response rates. At this particular point in the pandemic, we didn't have the luxury of being able to develop a sampling frame and trying to sample in a randomised fashion and do that. It was, the universities were speeding up the ethics applications. We were able to get the ethics application through fairly quickly, and so get into the field relatively quickly in terms of collecting this information, which is what we decided was going to be best to do, rather than developing a frame, going through that process and asking people to reflect on what was happening during these early months of the pandemic. Missing information was highly prevalent, especially towards the end of the survey. When you have an ad hoc survey group and you've got different people who are giving their input on the survey content, your surveys tend to get extremely long, extremely quickly, and it's pretty hard to negotiate what should and shouldn't be in the survey. And so towards the end of the survey, each of these surveys took about somewhere between 20 minutes and half an hour to fill in. Among people who were working during the pandemic, that's quite a lot to ask of them. We had social demographic information at the end. It was missing. Luckily, we did our main outcomes and independent variables at the start, but and our learning around how best to approach missing data also evolved over the pandemic. And I have references to the papers at the end, and you can see that if you go through the papers, that the way we approached missing data at the end was far more sophisticated than the way we approached it at the start, and I'm happy to talk about that. We were able to do some comparisons. So for the first two surveys, we did compare to the Canadian Labour Force survey, which was ongoing through this time. The usual suspects in terms of non-participation. So in terms of people who participated, they're more likely to be older, more likely to be female, longer job tenure, more likely to be working full-time. For the healthcare sample, we had terrible uptake in Quebec, which is I guess it's a predominantly French-speaking province in Canada. We don't know why that was. I think they were also doing a number of surveys at the time, and so it was hard to figure out. But we did manage to recruit what we estimated to be about 7.6% of the entire healthcare workforce at that time. In terms of the non-healthcare sample, again, more respondents from education, more older, more female, longer job tenures, and similar with the elementary teachers. We were able to compare that to the membership database, which isn't perfect because the membership database contains people who are no longer teachers, but were teachers at one point. But again, more women, older, longer job tenure, more full-time. So take that into account in terms of some of the information I'll give you. Okay, so I'm going to move into the main outcomes, which I'll be looking at today. So in the healthcare and non-healthcare samples, we used the generalised anxiety disorder screener, which is just 2 questions. Over the past 7 days, how often have you been bothered by feeling nervous, anxious, or on edge, not being able to stop or control your worrying? And people answer not at all to nearly every day. Scores can range from 0 to 6. Scores of 3 and above have a pretty good sensitivity and specificity with a physician-diagnosed general anxiety disorder. And so usually, as in this screener, if you score 3 and above, it's recommended that you'd go see a healthcare provider and have a chat about what's happening. Because we had seen in this initial samples that anxiety, so we also looked at depression. We did find similar-ish relationships. We did find anxiety was the one thing which was really elevated in terms of the samples. So in terms of the educator sample, based on what we had learned, we thought let's do a better job of measuring anxiety. So we looked at the GAD-7, which is it includes some additional questions about worrying, trouble relaxing, restlessness, being easily annoyed, feeling afraid. Now scores range from 0 to 21, and you can look at minimal, mild, moderate, and severe, as well as just using the 2 questions as the screener. So I'll be presenting information on both of these today, but slightly different measures of anxiety. In terms of the independent variable, and again, so this is a lesson in trying to be flexible in terms of designing a questionnaire. So we had this survey group, people who are in the field, giving us information on what they were hearing about things that were concerning or worrying, and I don't know, I'm sure you experienced a similar thing here in Victoria and Australia. Our understanding of what infection control practices were needed were shaping fairly rapidly throughout the first couple of months of the pandemic, from, a lot of sort of cleaning, touching, sort of washing hands, to increased recognition that transmission was possibly airborne, and so we needed to focus more on ventilation and asking workers to think about ventilation practices in their workplace. I don't know if any of you understood what the right ventilation was, or how to read a CO2 monitor prior to COVID. I certainly didn't, but I had to figure that out relatively quickly in terms of air quality. We asked people about, I'll go through the list of different infection control practices, We asked them whether that was a need in their workplace or not. So they said, yes, this infection control practice is needed. And then, or they would say, no, we don't need that in the work that we do. And then we asked them if the need was met or not. So was it appropriate and adequately implemented? Was it the right type of infection control practice, but it was not implemented properly? Was it inappropriate or was it just lacking? And so we identified people who had needs, and then how many of those needs were met. And then we grouped people into those who had all their needs met, those that had somewhere between half and all their needs met, those that had less than half of their needs met, but some, and those that had none of their needs met. In terms of what we asked about, so in the healthcare survey, we asked about 10 different infection control practices. We did also ask about PPE. I'm not going to talk about the PPE, but it's in the papers if you want to look at it, like things around face shields, masks, N95 masks, gloves, things like that. But this was more around infection control practices. So we asked about 10, which are listed on this side. We did include ventilation systems at the start. That was through OCAL's impact. But we looked about cleaning practices, cohorting of patients, having patients wearing masks, only symptomatic patients wearing masks, restricted access to people who are COVID patients in terms of moving around facilities. When we did the non-healthcare survey, because they weren't seeing patients, we had to change some of the infection control practices so they were relevant. So we looked at things around reporting. So were people who had COVID reporting, would they report it to the workplace? Was the workplace reporting how many people had acquired COVID during the course of their work? Ventilation, physical barriers. The perspex barriers, which I guess subsequently found out actually were potentially increasing the risk of people by trapping air. Isolation, physical distancing, different shift schedules, regular cleaning, sanitizing, disinfection. So we asked about that. Non-healthcare survey I've just discussed, but in the educator survey, we had to change it up a bit to ask about things around the cohorting of students, the screening of people coming into the workplace, face coverings. I don't know what it was like in Melbourne. Given our proximity to the US, by the time we did the educator survey, which was in November, wearing masks was a highly contentious issue, highly contentious. And trying to get students who are up to year 8 to wear masks, or people coming to the worksite to wear masks, was again a challenge in terms of administering and implementing that particular thing. Even worker face coverings was a fair challenge. So you'll see a difference in terms of the unmet needs in the educator survey, and that's predominantly around the lack of ability for schools to enforce mask wearing among visitors and students. In terms of covariates, I won't go through this list, only to say that when I present adjusted estimates, we're reasonably confident we've taken into account other things that are associated with infection control and other things that might be associated with levels of anxiety. Again, it did tend to shift a little bit throughout the pandemic as we were thinking about different things to measure. So, grades taught, which is down there in terms of the type of in terms of the workplace, that was only relevant in terms of the educators. Type of healthcare facility was only relevant in terms of the healthcare people. We did measure a number of different things at different times of the pandemic, and we were able to adjust for a variety of different factors and found out different bits of information around, people if they experienced symptoms, if they were still going to work, did they have contact with people outside of the workplace. So I'm reasonably confident we did an okay job of taking into account what we thought were potentially important confounders in the infection control to anxiety relationship. So just in terms of the prevalence, so this is the GAD2 scores in terms of the healthcare sample and the non-healthcare sample. So 55% of our healthcare sample had scores of 3 and above during that early phase of the pandemic, which is quite, just takes you back in terms of just trying to think about what those workers were experiencing at that particular time, where we didn't really understand what was going to happen in terms of the virus. We didn't really understand how it spread. It was a highly anxiety-provoking time. 42% of the non-healthcare sample had symptoms of anxiety of 3 or more. In terms of the GAD-7 scores for the educators, this is November to December 2020, Again, you can see almost 60% had moderate or severe anxiety, as mentioned by the GAD-7 during this time period. So there was a very rapid increase in COVID cases, and I think a lack of focus on what was happening in schools, because from the public health perspective, young kids didn't get severe COVID. So we didn't have to worry about what was happening to educators because, young kids don't get affected, but non-young kids teach those young kids. And so I think the educators were sort of feeling the brunt of that. In terms of the perceived adequacy of infection control practices, again, it did shift in terms of the different samples. We did have, if you think about the healthcare, which is in blue here, we had, let me add those together, just under 45% of people who had less than half their needs met in terms of the healthcare sample, just a bit over 50% in terms of the non-healthcare sample, and so quite a lot in terms of the educator sample, more than 65%. And again, a lot of that is around masking, the ability to ask students to mask, and the ability to ask visitors to the school to mask. In fact, there was a situation in Ottawa where teachers were told they weren't allowed to wear N95 masks. They had to wear just the normal, I guess, what do they call, the surgical masks, because I don't know why, but it was a lot of stuff going on. Okay, so now I'm going to talk about, I guess, some of the main findings in terms of the work that I'm doing now. Here I've got the different samples: the healthcare workers, the non-healthcare workers, and the educators. And these are, the adequacy is on the bottom of this slide. So from best case scenario, 100% of needs met, to worst case scenario, none of your needs were met. These are adjusted for the different covariates that I've told you about in the different surveys. I'm presenting them as adjusted prevalence estimates in terms of the scores of 3 and above. And so for the educators in this particular sample, I've just used the 2 screening items just so they're equivalent to the other samples here. And you can see this fairly stepwise gradient as infection control practices get more inadequate, anxiety symptoms get more prevalent. And that happened in terms of healthcare workers. The base is a little bit lower because it was quite a different time. At the top here, you can see that non-healthcare workers and healthcare workers with none of their needs met, and with less than half of the needs met, are relatively similar in terms of symptoms of anxiety, with educators being a little bit higher again in terms of how they felt when those needs weren't being met. We did look at the adjustment for the number of needs someone met. So is it this just about, if you said you've got a bunch of needs, you're more likely to have none of that, some of those needs not met. We did adjust for the number of needs that someone said, and it didn't do anything to change these findings that I've presented here today. So again, this fairly stepwise gradient. And if you think about what workplaces might want to do, if I said to a workplace, I've got this intervention you can put in place, it'll reduce the mental health of your workforce, it could potentially halve it. They'd say, oh, what is that? We're just providing actually infection control practices to your workers. It's quite staggering, just the distance in terms of some of those data points. We also were able to, in the non-healthcare sample, to look at people who were working remotely and people who had lost their jobs in terms of how anxiety symptoms patterned across that particular sample. And again, here we're able to show that workers who were able to still go to the workplace and had all their infection control practices met had lower levels of anxiety than workers who were working remotely. And workers who were at the workplace with none of their needs met, or with less than half their needs met, had higher symptoms of anxiety than those people who had lost their jobs. And so again, showing that here's a modifiable factor that's quite important in terms of people's ability and in terms of their mental health and symptoms of anxiety. In terms of because we had a little bit more variation in terms of the GAD scores in the educator sample, we're also able to look at the relationship between adequacy of infection control practices and moderate symptoms of anxiety and severe symptoms of anxiety. And again, we found this fairly steep stepwise gradient where they were both associated with both moderate and severe symptoms of anxiety, with a slightly stronger relationship when it came to severe anxiety symptoms than with moderate anxiety symptoms. We also did look at these differences in terms of the psychosocial work environment between educators teaching in person and those teaching virtually. To do this, we looked at we had some measures from the Copenhagen Psychosocial Questionnaire, which is the only measure of the work environment that's been validated in a Canadian sample. I don't know, you can't see that. I think that's some social support from co-workers down the very bottom there. So we looked at quantitative demands, so having enough time to complete your work task, work pace, predictability, being informed in advance of important changes, role conflict, contradictory demands, social support from supervisors, social support from co-workers. These are all scored on a 0 to 100 scale. The designers of the COPSOC have suggested that scores of 5 or more on those scales are practically important. So you've got statistical significance and then practical significance, and I've indicated that in terms of the slides I'll be presenting. We also looked at questions on burnout. So 2 questions on burnout and 2 questions on sleep troubles. And I'll present some information on those 2 questions as well. So in terms of differences between those that were teaching online, which is the blue, and those that were in person, which is the red. So these are the scores in terms of 0 to 100, in terms of demands. We actually did have a survey which was conducted prior to the pandemic on educators. Although there's no difference in quantitative demands among educators, the level, if you were to compare it to taking that measure in 2019, is quite different. About, I think it's about 15 points higher in our samples. We saw a difference in work pace, but it's statistically significant, but I don't think it's practically important. It was a difference of 4. People were both online and in person were working pretty hard in terms of the pace that they were asked to teach under. Predictability, much higher for those that were teaching in person. So that's good. Predictability, higher predictability scores means work's more predictable. So less things changing at the last minute, as we sort of experienced at the start of this talk, in terms of the ability to connect virtually and different students having trouble connecting and can you hear me and noise going on in the background. Role conflict, lower among people who are teaching in person compared to those online. And support, again, supervisor support and co-worker support, much higher for those in person than those online. We've got a couple of studies at the moment where we're looking at things around loneliness for people who are working remotely, who are there's a number of organisations in Canada that have moved to a virtual first approach, which is you're virtual, you're working from home unless you really want to come to work. We're a little bit different at our organisation, but I think there are important issues to understand about what's the right combination between remote work and in-person work. We didn't see differences that we thought were important. They were statistically significant, but not practically important in terms of burnout and sleep troubles. Potentially, this is fairly early. This is November to December. Schools had only just gone back where we could make this comparison in September. Maybe had we done a follow-up survey, we might have seen these differences starting to manifest. But at this point, we didn't see any large differences in terms of levels of burnout or sleep troubles, although remarkably high for both groups if you think about the scale from 0 to 100. So just some general strengths and limitations before I sort of conclude on some of the future directions. So strengths, large samples, a lot of variation in terms of exposures and outcomes. We had people in all the groups that we wanted to look at. We had variation across our outcomes. However, the samples are different from target populations in important ways. And so I would be cautious about generating a prevalence estimate for this is the prevalence among all people. Although I do think the relationship between independent variables and independent variables and outcomes may be consistent, even if the sample is non-representative. And that's a epidemiological debate, but I've got some points of view there. Results really only represent a particular point in time. and things were fluctuating wildly. I think by the time we got into 2021 and towards the end of 2021, workers were kind of done with being surveyed. Especially, I mean, one of the things that we had done in each of these with the labour organisations is presented reports back to the labour organisations. They could use those reports, report the results back to their members. Members could use it in terms of some of their negotiations. But I think there was a general over-surveying of workers at that particular time. Results are all self-reported. Exposures based on a perception of need. As I said, we did adjust for the number of needs and it didn't really make any difference. And also perceptions are important. So sure, you might say, well, we have adequate ventilation systems, but if your workers perceive you don't, then there's a communication thing that I think you need to do in terms of, well, you just need, so you might have the system in place, but you need to communicate about it a bit better. In particular, one of the things that we found in each of the samples was the number of workers who said they had no idea how many other people in their workplace were infected with COVID was quite staggering. And that was a big driver of anxiety, just not knowing what the workplace spread looked like. Okay, so these are the key findings. I gave them to you at the start. I'll give them to you again. Adequacy of infection control is associated with symptoms of anxiety in fairly consistent ways. 3 different samples, 3 different points in time. Among healthcare workers, non-healthcare workers, sorry, in around May, anxiety levels were lowest if you were at work with infection control practices being met. So people enjoyed the fact that they got to go to the workplace, but felt protected at the workplace. Among educators, we did note some differences in the psychosocial work environment, which I think require the use of more surveys to better understand these and better understand what's the right design in terms of hybrid work or virtual work if you decide you want to go in that direction. But people who are teaching online did have less predictability, more conflicts and less support, felt more isolated from their colleagues. All right, so some reflections. So in Ontario, despite the workplace being considered really early in the pandemic as an important site of potential transmission, our ability to understand what was happening in workplaces was completely uncoordinated and really incomplete. So healthcare units were collecting some information, public health was collecting some information, the Ministry of Labor wasn't really collecting information because it was a public health thing, not a occupational health and safety thing, but that was their take on it. But there was a lot of debate about, where's this information coming from? How is it working? Even simple questions when people went in for their PCR tests about, were you working last week? Were just not asked. What's your occupation? But again, would have been fairly simple to do. And we could have had a more complete understanding. Even things around transmission. I know in the UK, and people have talked about if the UK's response was adequate or not, but one of the things they did early in the pandemic was go into really large organisations where spread was likely to occur and figure out which workers were contracting COVID and which weren't. And I think that would have helped us understand. So in hindsight, by the start of 2021, we realised construction had terrible infection control, but really low rates of COVID. Well, construction's outside. Food manufacturing had pretty good infection control, but really high rates of COVID, but non-food manufacturing had the same levels of infection controls, but much lower rates. So again, it would have given us a lot more information had we been able to collect that data in real time to understand what was going on. So we ended up being reliant upon convenience-based samples, although this need has existed prior. Survey response rates in Canada, even for our national surveys, have been going down gradually over time. So, whether you want to refer to the Canadian Community Health Survey conducted by StatsCan as a convenience-based sample or not is up to you, but it does have a sampling frame, but the response rates are lower. We have subsequently got some work funded by the Canadian Institutes for Health Research on how to better recalibrate convenience-based samples. So there are approaches to weighting where you could use a representative sample with bits of information. Often that representative sample doesn't contain all the information you want, but if there was a second representative sample which also contained a bit of information, could you combine those to develop a new set of weights? And we did some preliminary work which showed it actually was quite promising, and now we've got some funding to really examine it through some simulation studies, which I think will be quite important. Stakeholder information needs were exacerbated during the pandemic, but I think remain, especially around areas in Canada around artificial intelligence and work, around mental health. Long COVID and return to work is where people want a lot more information. So we do have this constant need for what do you know? And as an organisation, often to say, well, we know some stuff, but we're just going to wait for peer review has created some tensions because people will go to other sources of information. And once people start using sources of information that aren't the Institute, our value as a provider of good information can be reduced. And so that's one of the things as we reflected on what's the role we can play. For us, obviously we'll try to get things through peer review. I think especially when they're controversial, they have to go through peer review. You can't put a report out on a controversial topic and rely on internal review to hold it up. So you do need peer review, I think in a lot of cases, but there might be other opportunities where we can get people around a table, unions, workers, employers, policymakers, to talk about some issues so that at least voices are being heard and we're having an informed discussion. And so that's one of the things we've set ourselves the role of as an organisation, is to be a convener around different groups for high priority topics, which we didn't do, I think, as well as we could have during the pandemic, but we do want to do around some of these bigger issues as we move forward. Okay, and there's some references. There's a slide deck which I'll be sending to Alex, which has all this. You don't need to look at that, and my contact information. And of course, if you want to catch up with the Institute's work, you can always subscribe to our monthly updates. I'm good. I've got 12 minutes for questions.
Perfect. Thanks, Peter. You should subscribe. The communications from the Institute of Work and Health are very informative. I get them regularly. I've got lots of questions, but I guess I just wanted to comment on that last point that you were making about getting information out quickly. My take on that, because it's a challenge we have as well, would be that it's better information coming from a rigorous source like you and from an alternative, less rigorous source. And so understand the balance. But I think as academics, sometimes we have to get through some of those sort of psychological barriers about peer review and things in our minds, because we want people using our work, and sometimes in things like this, when issues have to be addressed really quickly, peer review just takes a long time.
Yeah. So no, look, I agree, and I think for us, I think one of the frustrating things I think in Ontario was that any person, whoever, even people who were doing their PhDs in epidemiology, felt like they could talk to the media about different topics. And none of them had ever thought about the work environment, but were more than happy to comment on it, to comment on what was happening. We had healthcare providers who were in ICU wards who were giving us what they thought were the spread of the COVID pandemic based on the 12 beds in their ICU. And so it was a complicated time for us, because it's like, surely we can do a better job than these jokers. But I guess, do we want to? We did have a few scary moments. There was a Public Health Ontario published a study. I mean, how many times did you hear open access not currently reviewed, but on a repository? I don't know. So that was picked up during that time. Through peer review, they were asked to redo the analysis, and the results were different. And now they had one group lobbying based on their pre-pub, and then they had to come out and say, the results are quite different. So why did you, I don't know. It's
I read a couple of those examples here as well. I think it was the event that launched 1,000 celebrity epidemiologists, wasn't it? So we might ask for questions. Are there any? I might start with any questions online. Corinne, have you got any in the chat or? No? Okay, so we'll ask for questions in the room, and then maybe those online, feel free to type your questions in. Anyone want to? Deb.
Thanks. You didn't mention vaccinations, and if I'd been an educator, I'd have been much happier going to school if 90% of the kids were vaccinated. So, what was going on around vaccination? Was it available? Was it something that people were enthusiastic about, given your comments about face masks?
Yeah, so at this particular time, which is the end of 2020, vaccinations were starting to roll out, but only for healthcare providers and people working in long-term care homes. So educators weren't one of those groups. They could get vaccinated. In terms of the uptake, so in Canada, the uptake of vaccines was pretty good. We started with AstraZeneca until the head of the vaccine prevention task force was asked if she would recommend AstraZeneca to her close family and friends and couldn't answer the question, which was not great. But in general, the uptake we found was pretty good after the first and second shots was reasonable, and then it's dropped. I think now, if you think about the boosters, I think it's about somewhere between 5 and 10% of the Canadian population. But vaccines was something that people saw as necessary to reopen, and so they would do. Face masks was a personal choice, and I think most people were saying, well, look, I don't care, I'm not scared of getting COVID. So, well, it's actually not just about you getting it, it's about you giving it as well. So
we had a slightly different experience here in Victoria, I think, which face masks were mandatory in workplaces for quite a long time.
They were mandatory at that time as well. But it was just no one was enforcing kids coming to school without a mask and their parents coming to school to pick them up without a mask and going through the school to talk to them.
Interesting. Okay, Michael, and then Sam.
Great talk, Peter. I wonder if you could comment on the political environment in Canada. I'm aware there were very striking differences between so-called blue states and red states in the US. In Australia, initially, governments of both political persuasions were following the health advice, which was very encouraging. But later on, ScoMo's Conservative government started to play favourites. So Dan Andrews, who was the Premier of Victoria, headed a Labor government and was very strong on things like leaving the construction sector open and also enforcing the wearing of face masks, whereas Gladys Berejiklian, who headed the Liberal government in New South Wales, was much keener to leave retail open. And the Feds, who of course controlled all the funding and were responsible for the rollout of vaccination, were playing favourites. I just wondered whether you had those sort of challenges in Canada as well.
Yeah, so we certainly had variation across provinces. So at the time, and we still have a Liberal government. Liberal in Canada is more sort of in between Labor and Liberal in Australia. We also have a Conservative government and an NDP. We also have a Conservative Party and an NDP party as well. So there was certainly a lot of differences around. So in Ontario, we have a Conservative provincial government. And I'd say at the start, the provincial government had a science table. They were listening to the science table, but not always consistently listening to the science table. So there was one point during the pandemic where they closed playgrounds, but let workplaces stay open. And it just seemed a bit inconsistent between what they were picking and what they weren't. And there were the same issues around businesses reopening, the ability for people to dine indoors, what was happening. There were some industries which completely collapsed, and there was different. Also around just the amount of virus. So in British Columbia, the rates were a lot lower than they were in Ontario. So that sort of motivation. But I'd say there was definitely variation, but there wasn't any favourites in terms of the Liberal government the Liberal federal government giving more funding, because healthcare in Canada is done at a provincial level through funding from the feds, but they have a consistent funding formula for how they provide it. But there are still differences where masks were taken off in Alberta in healthcare settings. In fact, they were contemplating at one point making it mandatory that you couldn't wear a mask. So, but that didn't get through. But it was different situation.
Thanks, Peter. That was really interesting. I was thinking about the graph, the Copenhagen scale, and thinking about now, there's lots of people still working from home. You're hearing in the news all the time, there's people being productive, there's people not being productive, companies changing their policies all the time. Given that you mentioned that participation kind of dropped off because people got tired of being asked questionnaires all the time, what are your thoughts on how that sort of data can be collected now to inform those decisions going forward?
Yeah, so I think, you can still, I think people are still interested in work. I think actually the number of people who are interested in the work environment has increased, and people are happy to talk to you about their work environment. I think you just don't tell them it's about COVID and work, because then they're like, oh no, I'm like, I've done enough with that. So I do think I think people would be happy to talk about the work environment. I think it's trying to, so the productivity, again, this is not based on real, this is based on my own experience as an organisation, as the organisation I had. We also found that productivity didn't decrease. People could work just as effectively at home, but there were intangible things that did decrease, such as information sharing, opportunities for informal learning, sense of community. So people were now much more, they identified with their project team than they did with the organisation. We're an organisation of 60, right? So that's not that hard. And I think there's a lot of things around the remote work environment. So I don't think it's good. Like, I don't think it's completely good or completely bad. And I think we've just got to try to understand how it fits in terms of, I guess the conversations we have is the benefit for the employee versus the benefit for the organisation, and how do you balance those benefits if they're sometimes in conflict. So I think I don't know what the answer. We've struggled with it a lot, just as our own organisation, about what the right mix is. Even simple things around physical activity, like you're much more active when you go to work. You get out of bed, you leave the house, you catch the tram, you walk from the tram station, climb the stairs, and you probably feel a bit of a disconnect from work. Like you disconnect from work when you go home. So it's, but then the ability to, for our organisation, because we're a non-profit, most of our staff live a 45 to 1.5 hour commute from work. So to get back that time each day, to actually be able to attend your kids' after school event, because you can work from home and just go down to the school, is hugely important. And so for us, I think it's just around trying to figure out what the right thing to do is. So we are starting to collect more information now. People, I think, are happy to talk about their work environment. They're also, one of the big issues that people want to know about and workplace want to know about is around diversity, inclusiveness, accessibility, and equity in workplaces. What are workplaces doing? What's effective, and how that's playing out? And so I think, positioning it about things that are topical, I think, does allow you to still collect that information. Just don't tell them it's about COVID, because I think people are done with that.
So Peter, we've just got a minute or so left, and I know you need to get away. So if it's all right, I might ask the final question, which is a bit related to that, which is, you mentioned in your talk that getting these things up and running really quickly was challenging, but you had those connections in place with unions and organised labour. Do you think we've learned anything from the pandemic about the importance of occupational health surveillance in an ongoing way, so that next time something like this happens, we're better able to respond, given the links between work and health that you describe?
So I think there's a recognition that work's important. There's a recognition in Canada that our current systems are not adequate. And the problem is, to build the infrastructure so that they are, is not a 2-month project. It's a 3-4 year project. And keeping that momentum, I think, is going to be the challenge. So it didn't happen in Australia, but if you remember SARS, Canada was affected, Toronto in particular was affected by SARS. In fact, there's a couple of healthcare workers who died, and there was a whole bunch, things were shutting down, not to the same extent through the pandemic, but almost every single principle that was about the stocking of N95s, around the precautionary principle when it comes to infection control, were all, by the time SARS happened and by the time COVID happened, none of it was in place. And so I think that's the challenge, is the momentum to get to that point. And then even then, you need the momentum to sustain it. And that's, I think, going to be I don't want more pandemics, but it's almost as if without them, it's hard to continue to build the capacity. So we had some pretty reasonable collaborations with public health and healthcare. And everyone saw the need to have better work information in healthcare databases. And they still see the need, but trying to actually do it is a multi-year project. And at any point, you could have somebody's like, oh, why are we investing in this anymore? And then it's done. That's a challenge.
Yeah, I concur. I agree. Well, we're at the hour, and wonderful talk. Thank you, Peter. Thanks for visiting us. So online, give a virtual clap, and those in the room can thank Peter for coming. We have recorded this as well, so we'll make it available if you're happy for people to watch afterwards at their leisure as well. And best of luck with the rest of your visit to Australia.
Thank you. Thank you very much. Thanks everyone for coming.
Really interesting.
Again, that data, all the data